And this is a safer suicide talk. And Amy Malloy, I'm guessing, Malloy,
Yep.
not Molly. That's a whole different thing. Is going to be giving that talk. I'm Kurt Devine. Aaron is also on today, our other facilitator. Next slide.
We have some great talks coming up, so check those out. Our next session is going to be given by Dr. Charlie Resnikoff, and he is the Charlie Resnikoff and always amazing. So we hope you can join us. And other great talks coming up too. I'm really looking forward to the one by Haley Hillstrom and Troy Green from HIDA, just kind of discussing what we've been seeing at the national level for drug trends. That's always interesting to hear some of the changes and updates with that. Also listed at the bottom of the screen are other echoes that you can check out if you're seeking more continuing ed credits or just want more education.
And remember to get the free CME, you've got to answer the stuff that Katie sends to you. Don't ignore that email, just get that done. And remember that that Amy, I almost said Catherine, that Amy would love it if everybody was having their video on. So she was talking to people, not black boxes. So feel free to turn that video on. But again, when Katie sends you that thing, that's how you get your free CME. Please look.
And don't mind Kurt, lately, the last session, he called me Karen. So we just start answering to anything around here. Anything goes.
It just seemed to fit. I don't know.
Kurt always jokes, we're here for any of your needs, not personal maybe so much, but if you have any patient cases or need any policy or protocol advice, feel free to hit us up. We're always here.
All right. And if you want to go online to the Center for Opioid Resource Education, there's all kinds of stuff on there. So again, don't reinvent the wheel. There's all kinds of protocols, all kinds of stuff frequently getting updated. So sure can do that. And so now we will go to our speaker and we will let her share her screen because she was excited to do that. And we're talking about zero suicide.
Oh, it's just instead of keep saying, next slide, next slide.
Yep.
Looks
we'll
like
keep
Arizona.
on the chat for you too.
Okay.
So let you know if there's questions that come up.
Great. Thank you. Well, it is really a true pleasure to be here with you all today. Just a little bit about myself. I started my career, I guess, or my education in a substance misuse treatment program, intensive outpatient. And so this is just you all are working in a field that's near and dear to my heart. I haven't had much of an opportunity since then to work in this area, but I have a couple stories to share because, as you could imagine, just like in 1 year of an internship, I gained a lot of experience and a lot that has kind of stuck with me and continued to inform the work that I do even now. So really happy to be with you. We'll focus on the zero suicide framework. I'll describe what it is and we'll go through the elements. We'll talk about how it applies to health and behavioral health care, including addiction medicine, and I'll make sure that I leave you with some resources. We actually have a handout. I do want to just do a little bit of housekeeping here to say that the suicide prevention content and resources that we share through the Education Development Center, which includes the Zero Suicide Institute, is really intended to just be a snapshot of the resources that are available. It is it's a range of best practice options, but there's a lot more out there. And so we encourage organizations to take this information, bring it back to your leadership, to your teams, to decide what maybe is best and most appropriate for your organizations and the settings and the population that you serve. I'm coming to you as a member of the Education Development Center, which is a global nonprofit. Our work is in health, education, and economic development. And our project is called the Zero Suicide Institute. And we provide training, consultation, as well as resources. At the Education Development Center, though, we do have other suicide prevention-related programming. The National Action Alliance is housed at the Education Development Center, and we have been partnering with the University of Oklahoma to coordinate the Suicide Prevention Resource Center. So I want to turn my attention now to what zero suicide is. And just kind of by a show of hands, I'll take a look in the participant list here. How many of you are familiar for the most part with zero suicide? Just curious. I'll keep an eye out there for a show of hands. Not seeing a lot. So, okay. So if you have any questions, just by point of clarification, please interrupt me at any time. You can drop it in the chat, as we said, and I'll be sure to kind of answer those questions as best I can. So zero suicide is, at its heart, a continuous quality improvement approach. It's a way of transforming suicide care at the system level. And so why zero? And this is something that comes up a lot. And to be honest, there's some controversy and debate about whether it's the best way to frame this. But quite simply, the founders of Zero Suicide felt that one suicide is too many. And this is not a unique philosophy to suicide care. Both the airline industry, the nuclear industry, they all aim for zero accidents. And many of our healthcare systems are operating within this high reliability organization framework that really works to make sure that there are no accidents, no mistakes in the care that's being delivered. And so this is exactly the same. So we've adopted that zero mindset. And when organizations do that, they just function differently. It's about providing evidence-based tools and practices. It's about driving improvement using data. Specific to zero suicide, there's two other constructs that I think are really important that we have to talk about. And the first is engaging individuals with lived experience. So this could be attempt survivors, loss survivors. They're really invaluable to the design and delivery of zero suicide services in the framework. And I think in addiction medicine and in the recovery movement, there's a lot of really wonderful and important engagement with peer services, whether it's hired and maybe you have peers within your program or collaborating with community partners that have peers. When I was in training, so many of our clinicians had their own recovery stories, and while it may not have always been talked about or sort of have the same impact as a peer, it was known, and they were certainly sharing their stories at times when it was appropriate. So I think this is lived experience is really embedded into your programming as well. And another part of it is what we call a just culture. And that's a construct that's probably a little bit new to you. It's a little bit harder to describe, but essentially what a just culture says is that we're not holding the individual provider responsible. It is a system accountability. So when there is an adverse event, an overdose, a suicide, we're really asking questions like what happened, and then how can we do better? How can we improve our services? How can we ensure that this doesn't happen again? And so it's a little bit of a shift and thinking, but it's very intentional, and it really supports a culture in which safety becomes a priority, because people aren't concerned or afraid or fearful of what it would mean if they have an adverse event with one of their clients, or something happens within the system. That piece of it is removed. It's really about holding the system accountable and responsible for the safety of and well-being of the people we serve. And so the zero suicide framework was really developed initially in healthcare. And again, this is a bit of a shift, right? Because normally we were treating people with suicide thoughts and behaviors that was happening within the mental health system, within the behavioral health system. And that is true. But what we've learned is that there is really an important role here in healthcare systems. And so specifically designed towards the healthcare system, although we use it in behavioral health, mental health, addiction medicine. We actually are starting to explore how we can apply zero suicide in corrections settings as well, because corrections has often in a jail or a prison, especially in prisons, there's a pretty robust health and mental health services being provided. And so using the same zero suicide approach has, in a few places where it is being used, has been found to be pretty effective. So we're actually very excited about that. But what we know is that research has told us is that people at risk for suicide are often being seen in the healthcare setting. And But if we're not asking questions, if we're not screening, if we're not providing interventions, they're missed. So about 38% of individuals who made a suicide attempt were seen by their healthcare provider in the week prior. So that's about a third of people who make a suicide attempt were in their healthcare system the week prior. Nearly 95% visited a healthcare provider in the year before an attempt, which makes sense because we tend to use our healthcare system a little bit more. But that 38%, I think, really stands out for me. And so clearly there's an opportunity for us to identify individuals at risk for suicide in the healthcare system. And that's really where the Zero Suicide Framework began. And it's reflected in a lot of our national strategies and accreditation standards. So the National Strategy for Suicide Prevention was just released. It's goals 8 and 9 that really hold space for this. Essentially, what we're saying is that regardless of where an individual enters a system, the healthcare system specifically, they'll get services that are aligned with their current situation. So it could be a full assessment to determine their suicide risk level, collaboration on safety or collaborative safety planning, talking about lethal means safety, and getting them connected with evidence-based care. And then for those of you who are accredited by CARF or Joint Commission, same. You'll find as I talk through the rest of the session that there's a lot of alignment between the Zero Suicide Framework and accreditation standards. You'll hear things like how we keep the environment safe to minimize suicide risk. We'll talk about screening and risk assessments that are validated and evidence-based. There's great attention to documentation and also planning. So documentation for a patient's risk, but then also using that documentation of risk level to help plan the treatment and supports that are provided so that we can mitigate some of that risk, policies and procedures outlining care, as well as care transitions, which is that movement or from one level to another, or what we might think of as follow-up care. We call it care transitions in the Zero Suicide Framework. And then, of course, the monitoring of implementation and measuring effectiveness. So again, at its heart is a continuous quality improvement approach. Zero suicide is also not unique to the United States. It's a global movement. There is really a great network of implementers and innovators all across the country. There's some world. There's some really interesting things that are often coming out of Australia. So it is. There's just a lot of attention, and there's a lot of work being done, and that's helping us to identify new resources and new ways of doing things, and really also creates a lot of space for innovation, which I find particularly exciting. So the Zero Suicide Framework is made up of 7 elements. They are all important. Just implementing 1 or 2 is a good place to start, but just implementing 1 or 2 does not mean that it's a zero suicide system. It really is a holistic approach to suicide prevention and with a heavy, heavy focus on patient safety. I will go through each of the elements, but I like to think of them as kind of 2 buckets. The first is operational elements. So this is lead, train, and improve. And then the other 3 are the clinical elements, and that's identify, engage, treat, and transition. So I'll go through those in more detail. But because it is about safety, I want to turn our attention first a little bit to safety. And this image is adapted from James Reason's Swiss cheese framework of accidents. And it's Reason's position that the health and behavioral health, including addiction care, these systems can sometimes resemble a piece of Swiss cheese where there's like holes and gaps that people can slip through. And so I'll share a story from my experience that I often think of when I'm talking about the Swiss cheese model. So I worked with a client who was in his early 30s, and he was prescribed opiates for an injury. He became addicted, and when he could no longer get the prescription, he switched to heroin, not an uncommon sort of pathway. At the time, he had been using for about 8 years. And one night, for no other reason except that he was tired of using, he was tired of trying to come clean and relapsing, and he thought he had enough to overdose, and he was just going to continue to use until he passed out, fully believing that he would not wake up. At one point, he changed his mind. He called his brother, who called an ambulance. He went to the ER. He was admitted. Once he was medically stable, the plan was to send him inpatient, but there was no beds. This was upstate New York, so probably very similar to your communities. It was probably from where he was. It was probably a easily 3-hour drive to the inpatient center that they were looking to admit him. So as he was waiting for a bed, he was living with his brother, who was newly married, new baby, brand new baby. And he was discharged to our program, which was an intensive outpatient program. And he stayed there for, I think it was about 2 weeks. He went inpatient. Once he was inpatient, he made another suicide attempt. He was able to gain access to medications. I don't really recall what it was. And because he was sent home from the hospital, discharged early, and came back to our program. So my recollection is that at no point in that process was I informed of a screening or a risk assessment. I certainly did not do one when he came to us, although he should have, and we knew he was at risk because he had said he made an attempt. We did not talk about safety planning. We actually, at the time, used no suicide contracts, which have been identified really are not effective. But at the time, that's what we were using. And in conversations with his brother, who was a tremendous support, who's very, very lucky to have that support, all of our safety conversations were around how did we keep him away from using? Like, how could we support him in not using? It wasn't about suicide. It was about using. And so, and then when he came back to us, of course, again, not much information other than he used, it was a suicide attempt, and now he's been discharged. So when that is kind of probably not an unusual experience, and if I'm incorrect in that, let me know. But when I think about the zero suicide framework and how that applies, what should have happened, what could have happened in a zero suicide framework is that there were maybe multiple times to do screening and risk assessments. In a zero suicide framework, we talk about universal screening. So every patient, every time, every contact. So in this scenario, even though we know it was a suicide attempt, as soon as he was able, there would have been a risk assessment given to him in the emergency room to identify how high is his risk level so that we could then plan a course of treatment that was appropriate for that risk level. There would have been collaborative safety planning, which would have included lethal means safety that would have been gone beyond just the chosen method, but how do we help keep them safe? And then there would have been treatment for suicide. And I'll talk about this more when we talk about the elements, but for a very long time, treatment for suicide meant treating the underlying condition, whether it was mental health, an addiction, a grief, whatever, and thinking that that was going to have an impact on the suicidal thoughts and behaviors. And what we now know is we have to really treat it directly. And then that continuity of care. So lots of opportunities. When he came back, first of all, in the hospital, he should have been in a zero suicide framework. In a hospital, he would have been screened regularly for suicide and would have had that collaborative safety plan that he was working. And then when he came out of the hospital, would have gotten a screening from us as well. So when I think for me, it's a story that just really illustrates kind of the challenges with the work. And again, not saying this in the context of no blame, like we really didn't know. And if we knew, we just didn't know enough to understand that we needed to safety plan and not have just a no suicide contract. We know so much more now. This was probably about 12 years ago. We know so much more now than we knew back then. But the field is constantly evolving. And even now, every time I do an academy or work with our faculty who are implementing in the field, learning just new ideas and new information. So it is an evolving field. And I don't share that story from a place of blame, just as a place of illustrating all these opportunities that for us as a system, we missed and we could have done different. So the 7 elements, what are they? The first is lead. Well, and I want to say this too about the 7 elements. They are not like linear or occur in any particular order, although they look like they're a circle. It's just the graphic. They really do. They can happen in any way. It really depends on the organization and their needs, and they also sometimes like overlap. So when you'll hear when I'm talking about things like treatment, I have to talk about training because you need to train on interventions. And I'm always talking about improve because it's a continuous quality improvement process. So, but lead is really important. So it's a good place to start. And lead means a number of different things. The first is that for an organization to fully engage in zero suicide implementation, there needs to be commitment from leadership for a few reasons. One is, to a certain extent, it's going to require resources, not always funding. There are some things you can do with very limited funding, but staff resources and changes to policies and practices and a culture change. And so you can't do those things without the people at the top who are making the decisions. So leadership is really key, and there needs to be that explicit commitment and communication regularly. And so, for example, as part of our academy, we require that participating teams have a letter of commitment from their CEOs. There's also an organizational self-study. We recommend that this is done every 1 to 2 years. We also, as people, if they're attending one of our signature events, like our 2-day Zero Suicide Academy, we ask people to complete an organizational self-study in advance. This is really an opportunity to identify your strengths and opportunities for improvement. As I go through the elements, you'll probably hear there's a lot of things that you're already doing. So, where you put your energy and kind of where you plan your implementation efforts is going to depend on those places for improvement versus maybe things that are going really well for you. It is that culture of safety and no blame. So that's that just culture idea. And then of course the lived experience. And so we talk about all of these in this element. Another important thing is, and it kind of aligns with just culture, is postvention. And this is those policies and practices that promote the culture of safety, that support worker wellness, particularly when there is an adverse event. And postvention, if you're not familiar with it, really does include 2 very important components. One is there's specific efforts to promote healing when there is an adverse event like a suicide loss or an overdose. And the second is to reduce risk, because particularly with suicide, what we know is that when individuals are exposed to a suicide death, if they're already vulnerable, it can raise their risk level. So in a community where there has been a loss, we want to, of course, support healing, but we also need to be mindful of how we can mitigate that risk. And so I'll share another story with you from my experience. It was, so I was an intern for a year, and it was early March. A client I'd been working with from the beginning died by suicide. And I had a tremendous amount of support from my colleagues, from management, even from his family. But outside of 1 or 2 supervision times and of course the critical incident review, we really didn't discuss it. There wasn't a lot of conversation about what happens and what can we do differently? How can we improve our services? How do we reduce the likelihood that this is going to happen again? And in addition to that, from a postvention perspective, we also didn't have a lot of conversations with the clients that we were serving. And aside, I know for sure that our clinicians in one-on-ones talked with their clients, but in groups, I mean, we were in, this was a full intensive outpatient program. And so we were running groups every day. So this individual was in groups with many people, many different people, and had been in our program for, at that point, 6 months. So there was an opportunity to have conversations about it, about his death, about his suicide, and we just didn't have them as a group. And so I think we backed away from conversation for many reasons. I'm sure liability being one of them, fear of additional suicide loss. And this was a missed opportunity. So in a zero suicide framework, we really put a lot of attention on post-vention just culture. And of course, it's going to look different in every program. If you are an outpatient behavioral health and you're not running groups, then you might not have as much of a conversation. But to be able to offer support for people in the community who are aware of a suicide death is really important. And sometimes it happens in the organization, sometimes it happens at the community level. Another key part of the lead element is implementation, implementation teams. And so this there's a lot of work to do, and I'm going to have to run through the elements really quickly, but there's a lot of work to do. And so we recommend a multidisciplinary team, and deciding who's on your team is really important. We recommend that you include, leadership that is in a decision-making position, quality assurance, your safety and risk management staff. Your IT staff is a great asset, I think, in an implementation team, because many times we're building workflows into electronic health records. We're pulling data from electronic health records. So having your IT team available is great. I mentioned that communication is a really big part of zero suicide, communication from the top. And so somebody on your communication team is also a benefit. But then you want lived experience. You want your direct care staff. You want your clinical staff. You really want a nice, robust, multidisciplinary team. Then you got to think about, like, when do you meet? And how do you structure your work? How do you communicate your work to staff? So the implementation team is a really key part. I did provide a handout with links to some resources. So some of the things that I included were the organizational self-study, some messaging materials that we have so that you can raise awareness among your staff of what zero suicide is and why we're doing it. And then we have a readiness building guide, which is really kind of structured around stages of change model, which again, I think is very applicable to the work that you all do as well. So second element is train. As you can imagine, if you're implementing any changes, new interventions, training is going to be really important. But we also want to train about what is zero suicide. Zero suicide is an internal message, by the way. So you're not going to necessarily communicate to your clients or your community that you're a zero suicide organization. In part because there's all those challenges of, that I mentioned with the name. But, what happens if you do have a loss? Does that mean that you were not effective? Not necessarily. So it's a hard sort of conversation to have. So it really is an internal message, but it is important to raise awareness with your staff, the people you serve in your communities about suicide prevention. But that's kind of outside of the framework. You also want to train your staff about the why we're implementing it, because you're going to be asking them to do some things differently. And so part of sort of motivating them and sort of gaining their support is the why. But then you want to train individuals on their role. What is my role? And in a zero suicide organization, everybody has a role. So you train like if you have people who transport individuals to and from your program, or partners, you're going to train them because they may hear something and they need to know, how do I respond if I'm concerned about the safety and well-being of somebody in my in my van, or our front desk staff, our financial staff. That's another important one because they're talking to people on the phone. They might become aware. So everybody has a role. It's just different. And then you want to assess your staff for their knowledge and never assume that your staff has training in suicide safety planning or treatment. We've learned that it's not a part of a lot of pre-service programs for even our clinical staff. And I was recently hosting an academy, and we had, as part of we have this 2-day academy, and where we train organizations in the framework and give them time to develop their own action plan. And we have implementers, our expert faculty who attend with us. And one of them was sharing that they had done a full assessment with their staff, this zero suicide workforce survey. And what they found was that their non-clinical providers, their medical staff, had just as much training and knowledge about suicide as their PhD and master's level behavioral health clinicians, which did not mean that everyone had a lot of knowledge. It meant that everyone had a little bit of knowledge, and even those that you would expect would have more awareness. So the assessment is the workforce survey is really an important part of zero suicide, being able to understand not just the competence of your staff, but also how confident do they feel in zero suicide, and what are their beliefs? Because there's a belief that's pretty prevalent among your system that if someone's thinking about suicide, there's nothing I can do to stop them, or only certain people, maybe they identify as being more at risk for suicide. If that's sort of the beliefs, then it contributes to the culture, and we need to be aware of that. So the workforce survey really does get at not just competencies, but kind of beliefs and attitudes as well. And so I did share the resources. You'll see this one here says Zero Suicide Workforce Survey in Indian Country. We have a adaptation to our toolkit that is specifically designed for Indian Country. And so that just happens to be a screenshot from that toolkit. We also have a kind of a matrix, I guess you'd call it, of trainings. And it breaks it down for, individuals who provide direct care, clinical trainings, individuals who maybe do not, like what is some basic suicide awareness training you want for your financial staff, your transportation staff, your custodial staff. And so this is just a snapshot of that matrix, and some specific trainings for populations such as the emergency departments. So the next element is improve. As I said, this is a continuous quality improvement model. And so we look at the data, we use that data to inform our improvement process, looking at both fidelity to those process measures as well as patient care outcomes. So not just completed suicides or attempts, but also are people getting screened as often as we want them to get screened? Are they getting safety plans? Are their safety plans collaborative? Because everyone's safety plan should look different. It should be person-centered. So if everyone's safety plan looks the same, then we want to take a look at that. A question that often comes up in systems like that are providing treatment for substance use and misuse is, how do we define an overdose? Is it suicide or is it accidental? And many systems choose to go with whatever the criteria is, as defined by their coroner. However, there's also some flexibility to really attend to what is the perspective or perception of your staff and of the community and of the family. So maybe a death has been ruled an accidental overdose, but if it feels like it could have been a suicide, then we want to provide the same support that we would if the family believes it was a suicide. That's okay for us to, follow their lead on that. How you sort of define it, though, for your quality assurance approach is going to look a little bit different. You could go with the coroner's office, or you could make your own determination. As long as you're consistent, this is really about that quality improvement. And you could also have another sort of category of unknowns or undetermined too. So that it is a question that comes up. So much of this work is defined by the organization. And as long as you're consistent with your definitions, then that is okay, because it's really your quality approach. As I mentioned, one way to support quality improvement is embedding the workflows into the electronic health record. So we do a lot of that. We also talk a lot about the importance of communicating the data and how it's being used for improvement process. And then, of course, with this continuous quality improvement, we circle back to that culture of safety and topics like postvention and just culture, and wanting to sort of look at it all through that just culture lens, and continue to work to support that culture of safety. Something that is taking on some movement is applying a restorative justice lens to this work. And I think there's still a lot to learn and to think about here. I think in some communities where there is like a strong restorative approach, sometimes we see this in some urban communities, then it very much makes sense that the organizations might begin to adopt a more of a restorative approach to their just culture work. In a restorative approach, similarly to just culture, we're thinking about, what happened, but also as we start to think about who was harmed, sometimes that may include the family, or it might include the other clients in our care, or individuals out in the community at 12-step programs. So really thinking a little bit more broadly about how do we provide that postvention response, provide some opportunities for learning within the context of a just culture. And, how much of this does the organization sort of take on as their obligation to help meet the needs of those who were harmed, and how do we put things right? So there's a lot, I think, still to come in that, but I think it's a really interesting approach, and something that in some communities is really very important and relevant. We have on the Zero Suicide website a data dashboard to help in organizations collect and manage their data. It is set up so that there's one account for each organization, and you could assign multiple users so that you're collecting data maybe from multiple service lines. But we look at things like screening, assessment, safety planning, lethal means, and a few other measures. And then there's lots, as I said, the Zero Suicide is really a global movement. And so on our Zero Suicide website, we have lots of information and stories from organizations across the country and across the world that are using Zero Suicide. So as a way of like learning from them, lessons learned. So that's the organizational components. The clinical components begin with identify, and that is just how do I identify people who are at risk. And the practice is that we are using evidence-based tools for screening and assessment. We are, again, every client, every time, every contact. There's workflow that helps guide that work, and being embedded in the electronic health record really sort of ensures compliance. Training, who needs to be trained? How do they get the training? How do we support them? Not everybody, say, for example, who is going to do a screen needs to be a clinician. We can screen peers, or we can train peers to do screenings. We can train intake staff to do screenings. We could train nurses to do screenings. And then how do we monitor it, the data collection? So with every component, there is this strong attention to training and improvement. There's many validated tools. Some of them are better for different settings. This ask suicide screening questions is for a younger population. Some are already being used in healthcare systems like the PHQ-9. So we can absolutely use that. Others might look at some others like the Columbia. And then the assessment piece is very separate. So you do a screen, it's brief, someone's identified as positive. Now we're going to continue with a fuller assessment to understand the level of risk. Because just because someone has said, yes, I'm having thoughts of suicide, doesn't mean that they're going to get the same care as the next person. We really want to differentiate that care in our approach. And for us to do that, we have to assess for the risk. And I could have talked about this anywhere, but really throughout, there's just a need for cultural considerations, thinking about stigma and how it's viewed. This is true for suicide as it is for substance use and misuse. We try to encourage organizations to engage with their communities so that they can, identify maybe some cultural brokers in the community who can help us understand the beliefs in the community and the people we serve. So we're at the same time we're seeking that information so that we can learn. We're also, really being intentional about being open and accepting, of course, of individual differences, and open and accepting to the idea that there may be a need or desire for other treatments and supports outside of what we would recommend with zero suicide, such as traditional healers or community supports. The engage element has three components: safety planning, lethal means safety, and the suicide care pathway. So some of you may be familiar with the Stanley Brown safety plan. This is only used for suicide. So if someone is not having thoughts of suicide, you still might have a wellness plan or some other crisis plan that you develop with them. The Stanley Brown is used intentionally for suicide. So it might be a little bit different. Some people may have more than one plan depending on their needs. A part of that is lethal means safety. And so this is an important part of the safety planning, often involves families or other collateral contacts to offer support in helping the individual identify a plan to keep them safe, but also manage that plan. So if we need to keep someone safe from medications, what's the best way that we can do that? And is there someone who can provide support for that? We really focus on their chosen method because we know from research that if we can put time and space between an individual and their chosen method, they're less likely to find another method. That is not the norm. It's not automatic, but it is important, I think, to consider other lethal means. And there's some great training that's available. This is freely available. It's online. It's self-paced. It's a great training. There's a lot of really good free resources on the Zero Suicide website. And then the last is suicide care pathway. And in this, we really define what care will an individual get based on their level of needs. So again, this can look different from one organization to the next. You're really thinking about your assets, your community partners, what can you do? What can you manage? You can't manage everybody to be on a suicide care pathway because that includes some extra attention and supports and services. So how do you define eligibility? So some organizations will say it's only people with moderate to high levels of suicide risk. You decide that for yourself as an organization. This is another one of those places where it's really defined by the organization. But in this care pathway, there's clear expectations. What is the individual's responsibility? What is our responsibility as a care provider? We're talking about their evidence-based treatments that they're going to receive for suicide care, as well as their care transitions. And there's, again, this focus on it being very collaborative. We want to engage individuals in their care, providing as much support as we can. At the same time, when we sort of approach this work in this way, we're supporting our workforce because we're providing them with the very clear idea and understanding of what's going to happen. They don't need to make a whole lot of decisions. There is room for clinical judgment and risk assessment and in developing the care pathway. But we want it to be standardized at least enough so that our workforce can really just lean into being there, being present, showing empathy and compassion and doing the work that they need to do, that they want to do. That's why they're here. But taking a lot of that kind of guesswork out of, well, what options are available to us? Our staff can spend a lot of time trying to figure out what are the best available options. If we can create these pathways that are standardized and stable and accessible, we can at least make it easier in that sense. So, this is an example of what it would look like. We have a document on the Zero Suicide website that sort of shows this as like a standard suicide care pathway, but then also includes those decision points and questions that you need to ask in designing your own program. It's also important that we educate our individuals that are at risk with what is a care pathway, what can you expect? And so we have an example of that. And as I mentioned, there's this really ties together with worker wellness. And so there's a lot of those resources. I'm coming to the end here. We have transition and treat. Essentially, when individuals move from one level of care to the next, they are at a greater risk for suicide. And we see this particularly from inpatient to outpatient. So an individual who is seen in a psychiatric center is at a 300% increased risk for suicide when they when they leave inpatient and go outpatient in the first week, and that risk lowers to 200% in over the next 30 days. So there is and that is just one example. This is true for all transitions. And when we think about like the correction setting, we're thinking about moving from jail to prison, or even prison reentering into the community, or moving from one facility to the next. So I think actually relapse can be another a time of high risk. And so care transitions and strategies can be really effective in providing that little bit of extra support for individuals, people who leave your program abruptly, who choose to leave, who there's a term for that and I can't think of it right now. But they too, we often end up sending letters that say, if we don't hear from you in X number of days, we're going to close your chart. What Zero Suicide says is when they stop coming to care, we need to just continue to follow them a little bit and see if we can keep them engaged and we can keep them getting support. If they don't want treatment, but they're just going to do 12-step programs, then what support can we provide them at that time? And so it's really increasing that level of safety and support for individuals. Lots of different ways to do it. Peers are a really big part of that. One of the ways is called the caring contact. This is non-demand caring contact. This was tested originally in healthcare settings, but it has been very well documented and very well effective. It's simply a postcard, a letter, and it can be a text or an email that says, "Hey, you got this," or "We're here for you." Not did you fill your medication? Not did you make your appointment? Are you using your safety plan? All of that is requiring something. This is just saying we're here for you, and it can be very effective. Identifying what's the best fit for them is really important. So like I said, they maybe leave your program because what they want to do is just attend 12-step meetings in the community. Is there anything we can do to provide support for them? Maybe it is just sending those non-demand caring contacts to keep that engagement so that if they feel like they need more care, they can come back. And it's a very different sort of philosophy and approach. Lots of great resources on that, including an article that talks about the cost savings when we use care transitions. And then the last I just want to mention is that treat element. And I said this earlier, it needs to be evidence-based for suicide care. We can't just treat an underlying mental health condition and think that the suicide thoughts will go away. We talk about it also being done in the least restrictive setting. So again, not everyone who says I'm having thoughts of suicide is going to go to the emergency room. Some people can be managed with safety, with a collaborative safety plan, with supports in their own home. And so that's really what we're looking at. There is also brief micro interventions like safety plan, collaborative safety planning, DBT skills groups, support groups. There's a few resources on the website that talk about those specific treatments and includes a suicide prevention sort of module of CBT. DBT is another one. And Dr. Jobs from Catholic University has created a program called CAMS. As I mentioned, we have adaptations to our toolkits. So we have one for Indian country and one for youth. And the rest I have really are just some resources, which you have them on the resource list. So I think I'll just kind of end it there and see if anyone has any questions. I could always come back to this if we have time.
That was great. Thank you so much. I have a question, and it's sort of surrounded specifically around correctional healthcare.
Okay.
I think the struggle is, and what I keep going back to is most people that have been justice involved previously, they know what happens if they disclose that they're having suicidal ideation, right? You get put on suicide precautions, put in a smock, it's unpleasant, as it is in many other areas of healthcare too. So I'm thinking back, and it's like most of the suicide attempts and successful attempts that I've seen, folks have answered or not disclosed on the CSSRS that they're having any suicidal ideation. And, I always talk to staff, like pay attention to their body language and eye contact and things like that as well. But how how do you get to the root of this so you're better identifying people because they are very hesitant to disclose because we sort of have this like punitive light on our interventions in healthcare.
Amy,
Yeah,
did you want to
absolutely.
stop? Did you want to just stop sharing your screen and then we'll
Yeah, I can do that.
everybody will be pop up. There we go.
There we go.
Go ahead.
Yeah, so that's a great question. And I think that is why zero suicide really needs to be done with this holistic approach. Because if we're just depending on, say, that screening or that assessment, we're going to run into some of those challenges. I think the culture change that needs to happen is really important. I think in any system, if we're messaging that our beliefs about suicide, our belief that, we can prevent suicide, that we have these safety mechanisms and these practices and procedures in place. I think that is really important. But the idea too of that every contact, every time also helps to send the message that we're really serious about this because we're going to continue to ask. But the hope is that maybe a different person, a different setting, a different time, someone is going to respond differently because we've continued to ask. But there definitely, especially in like a correction setting, there needs to be an understanding that it's not automatic that if you say yes to a screen, that this is what's going to happen to you. And so we are really changing all of those processes and sort of pathways. So, safety planning, what would that look like? And I think this happens in communities as well, where, I think like I'll use the example of a school. A child says that they're having thoughts of suicide, they're immediately sent to the emergency room. And sometimes they're waiting in an emergency room for a really long period of time, and so then next time they're not going to say that. So we have to change how we respond. If we respond the same way every time, we're going to continue to get the same, challenges. We need to change our culture. We need to change the way we talk about it. We need to message that as well to the communities that we're serving, and regardless of what the setting is.
Yeah, Dr. McClure, did you have a question? I saw you suddenly pop up, so I want to make sure you didn't have a question before I jump in.
I was done eating, so I turned my video back on. But I do have a question/comment. And Amy, it's not at all to disparage what you do, but I was recently on a CME/forum discussing a very similar topic. And it was brought up, but it seems that the more resources we put into this, or in spite of all the resources we continue to put into this, suicide rates are still climbing. Mm-hmm. In almost all populations. How do you respond to that, since this is a fairly resource intensive program, and across society, across most population groups, it's not all that effective?
Yeah. So I think one of the things we honestly say to organizations who are starting this work is you are going to find your numbers increase because you're going to be screening and asking questions when you haven't before, and you're going to get more responses. So some of there will be some very natural increases in your patient outcomes because you are screening and you hadn't been screening before. And I think it's similar when we think about suicide deaths. For a very long time, there was, and even still, there's not a lot of consistency in how suicide is reported. As that has changed, as awareness has increased, we are going to see higher rates. I think that's generally what the response from the field is, that there's some of this is that we know more, we're raising more awareness, and so we're going to have higher numbers. But that does not account for the entire increase. We definitely have a problem across the country, and that is just more reason to do the work. In terms of the resources and it being resource intensive, I think the other thing to consider is how it aligns with, as I said, accreditation standards. Some of this is needing to be done anyway in organizations. So there is that alignment. It also fits nicely with trauma-informed approaches. So there is some alignment with other initiatives that I think helps to sort of frame the cost for it, and the resources that are used are not solely for zero suicide. They do support a lot of system efforts.
Is there a demographic that lately has risen higher? And I guess I asked that more based on social media.
Yeah.
Right?
Yep. Yeah, we are seeing mostly populations like Hispanic females, Black youth, particularly younger Black youth. Um, and we see a lot of Native American increases recently, also youth, which is different than the white population, where our highest rates of suicide tend to be among middle-aged to late-aged adult males.
Hmm. There was somebody that was. Oh, go ahead.
I saw some recent statistics too, that women suicide rates are increasing at a faster rate than they had in the past.
There was a question in the chat about, do you use the ASQ? And I would have to say
Yeah.
what that is.
Yep.
Go ahead.
So that's that is one of the validated screenings tools, and so we do recommend that could be an option. It is typically used for youth under the age of 18, but sometimes it's used also with individuals with maybe some cognitive delays.
Hmm.
And then there's another one. So, I'm glad you asked that question. On the Zero Suicide, not on the Zero Suicide website, but on the Zero Suicide Institute website, which is my project, we have just launched, I think it's on there now, a list of organizations that we've worked with. And the next thing that we're going to launch is a list of organizations that are implementers. So we expect that to be up by the end of this year, by the end of the calendar year. There are lots of organizations that are doing zero suicide implementation, and they have shared their stories. So you on the Zero Suicide website, and I think I have it on the resource list, there's a section called Outcome Stories. Those are organizations that have been doing zero suicide and have some outcomes to demonstrate their effectiveness. We recently added Journey Stories, which is we were working with Pew Charitable Trust and a learning collaborative of 7 organizations, and they have all shared sort of their journey and sort of their progress from the beginning to where they are now as part of that collaborative. So there's definitely a lot of information out there on their website with specific organizations if you're interested.
I have another question unless somebody else has one. If you have one, unmute. Unfortunately, in my practice in the last lots of years, I've had quite a few suicides, and interestingly, as you say, oftentimes you do see these patients the week or two before, right? Is there a common diagnosis, or is it a mental health issue they come in for, or is there any kind of pattern to what people come in for prior to that?
Yeah, there really isn't. And that's why we advocate for universal screening. There was a time where we really believed that most people who died by suicide, I think it was like 90% was the statistic that was quoted for a very long time, had an underlying mental health condition, but sometimes that was undiagnosed. And so it's really hard to know. And that's why we advocate for every person, every time, whether you come in for a broken arm, you come in, for a checkup, universal screening. And we look at it as just another one of those vital signs. So just like we check your blood pressure and your temperature, we want to ask some questions about suicide. And the screen itself, like the PHQ-9, doesn't take very long at all.
Yep. All right. Any other questions before we go? I've reached our time. Really appreciate you coming, Amy. That was a really eye-opening discussion. Again, I don't think there's anybody on this call today that hasn't experienced these kinds of issues with patients and had somebody that is in their panel commit suicide. So I think we've all kind of been there. So thank you so much for kind of bringing this to the forefront.
Thank you for the opportunity. I appreciate it. And you'll have the resource list as a follow-up, and I'm not sure that my contact information's in there, so I'll just drop it here. And happy to continue the conversation at any time.
Perfect. Anything else, Aaron? Am I missing anything?
I don't think so. Once again, I'm super appreciative that you were able to present for us today, and thanks for all the resources.